Hello everyone, I am Dr. Rohit Solanki. Welcome in my YouTube channel Radio with Rohit. Today we are going to discuss one very interesting topic, medulloblastoma. Medulloblastoma. Medulloblastoma is most common malignant, I repeat, most common malignant CNS neoplasm of childhood and second most common pediatric tumor. So question is which is the most common? So pilocytic astrocytoma is most common pediatric tumor and most common malignant CNS neoplasm of childhood is the medulloblastoma. Origin of this medulloblastoma is from this embryonal neuroepithelial cells. This is the neuroepithelial tumor. Cerebellum and a dorsal brainstem is the most common location. So, on histopathology, we will get the lobules of the uniform small round blue cell. Here we can appreciate that round small blue cell are uniformly arranged like a ship, and here we can see that round to oval blue cell are arranged like a Homer, right? Rosette appearance. They are perivascular pseudo-rosette. So far, medulloblastoma is the most common malignant CNS neoplasm of the childhood. Second most common pediatric tumor. Origin per se, they are the embryonal neuroepithelial tumor and most common location is cerebellum and dorsal brainstem. Lobule of the uniform is small round blue cell like this and homogeneous rosette appearance like this on histopathological slide. Here we can see that the medulloblastoma are a small uniform round blue cell, so a small uniform round blue cell with little pleomorphic. This pleomorphism is a homobright neuroblastic rosette. Homobright neuroblastic rosette. So classification of the medulloblastoma is very easy. First, they have classified it under the histological basis, so histological defined medulloblastoma, and they are classified it under the genetic basis, so genetically defined medulloblastoma. Histological defined medulloblastoma, we have most common 90% medulloblastoma is the classical, rest are the variant of the medulloblastoma. They are like nodular medulloblastoma or desmoplastic medulloblastoma, extensive nodularity medulloblastoma, and large cell or anaplastic medulloblastoma. So, on histological basis, there is a very simple classification. One is the classical, rest all are the variant of the medulloblastoma. Invariant, nodular, extensive nodular, and anaplastic medulloblastoma are there. Now, according to genetic basis, medulloblastoma are divided into the four subgroups. First one is WNT activated medulloblastoma. It's simple WNT activated medulloblastoma. SHH activated medulloblastoma. They have either P53 wild type or mutant type and non-WNT, non-SHH group. So they have the group 3 and group 4. So classification of the medulloblastoma is very easy. They have histological or genetical. Under the histology, we have either classical or medulloblastoma variant. In variant, you have either nodular or extensive nodular or anaplastic medulloblastoma. In genetically defined medulloblastoma, we have the WNT activated, SHH activated or non-WNT, non-SHH activated medulloblastoma. What are the classical medulloblastoma? Actually, 99 or 90% of the medulloblastoma are the classical. Classical medulloblastoma is all four molecular subtype. It means it has WNT, SHH, non-WNT, non-SHH variant. But interesting thing that all the WNT activated medulloblastoma leads to the formation of the classical medulloblastoma. So all four molecular subtypes represented by the classical medulloblastoma, but almost all WNT activated medulloblastoma are the classical medulloblastoma. The most common location of the classical medulloblastoma is the dorsal midbrain and more precisely fourth ventricle and more precisely is the roof of the fourth ventricle. So we can see that classical medulloblastoma arising from the roof of the fourth ventricle. On pathology per se, it is 95% are there, they are midline. They have the small round blue cell like we just saw, neuroblastic, homobright rosette and WHO grade 1. So here we can see that this is our cerebellum and this is our medulloblastoma located in the midline. Here we can see that medulloblastoma is present in the lateral aspect of the cerebellum, or we can see that it is herniating through the foramen luschka. This is another picture of the medulloblastoma which is present in the our cerebellum or the part of the fourth ventricle and the cerebellum. Here we can see that medulloblastoma is infiltratively present in the cerebellum. So medulloblastoma has the variety of presentation, but 85% of the medulloblastoma are present in the midline of the fourth ventricle. It could present laterally or diffuse or infiltrative type of the medulloblastoma. So far we have read that classical medulloblastoma is a classical medulloblastoma. All four molecular subtypes, I repeat, WNT, SHH, non-WNT, non-SHH, but all the WNT activated medulloblastoma leads to the classical medulloblastoma. So classical medulloblastoma from the dorsal midbrain and more precisely fourth ventricle, and if we will talk more precisely, there will be roof of the fourth ventricle. Pathology 85% midline, small round blue cell tumor, neuroblastic, we have the Homer bright rosette appearance and WHO grade 4. Those clinical features are all pediatric brain tumor in 20% are the medulloblastoma, and among them the 70% are the classical medulloblastoma. Most common malignant posterior fossa childhood neoplasm is the medulloblastoma, and most classical medulloblastoma in patient of the less than 10 years. So this is the pediatric age group tumor. Second peak could come in between the 20 to 40 year of age. Low risk if the WNT activated medulloblastoma is there. So clinical feature, patient will come with a vomiting, headache, psychomotor regression, ataxia, strabism, or spasticity. So this is our child, 10 years old, came with the most common malignant brain tumor with a headache, nausea, vomiting, dizziness, visual disturbances. Tumor can compress fourth ventricle. If it will compress the fourth ventricle, it will lead to the hydrocephalus, and majority arises in the cerebellum. So relative to define, it's have the margin. So here we can see that it is a relatively well defined margin. It has the foci of the calcium within it. It has the foci of the hemorrhage within it. So it is a well defined round oval dominated on the gross pathology. So interestingly, if we will imagine one mass with central cystic lesion with peripheral stipple or the microcalcification in the areas of the hemorrhage, so this is all about medulloblastoma. So here it's on CT scan, it will be the hyperdense. On NCCT here we can see that this is our cerebellum and this is our fourth ventricle location. Here is the round to oval, very relatively well defined mass with hyperdense non-contrastivity and with intramural hypodense. So intramural cyst, it could present in 40% cases. There are focal calcification in the 20-25% cases, and hemorrhage could present, but they are rare. On post-contrast study here, we can see that it is giving the strongly enhancement on post-contrast study. Here we can see that this is our mass which is going the enhancement, homogeneous enhancement here, but it is compressing over the fourth ventricle leads to the dilatation of the ventricle system and hydrocephalus. So on plain contrastivity, there is a hyperdense mass lesion round to oval well defined lobulated with the central hypodense cystic area with the stipple calcification and the hemorrhage. On post-contrast study, it will give the homogeneous enhancement and will lead to the hydrocephalus or the compression over the fourth ventricle. So next we are here with the MRI. On MRI, we can see that on T1 weighted image it will give hypointense, and in T2 there will be hyperintensity. DWI, it shows the restriction because the tumor cells are very compact and hypercellular tumor which is showing the restrictions on the DWI. So hypointense on T1, hyperintense on T2, showing restrictions on DWI. On FLAIR imaging, peritumoral edema will be there. So peritumoral edema, it's because of the obstructive hydrocephalus with the periventricular accumulation of CSF. So if the obstruction is will be severe, then edema will be severe. On contrast study, minimal or marked enhancement will be there. On perfusion weighted image, there is a low relative cerebral volume, while on K2 map there will be increased permeability. So here we have the T1 weighted image. Here we can see that the hypodense round oval well-defined lesion present here on the roof of the fourth ventricle, iso2 hypointense on its appearance. This is our T2 weighted image because here CSF is wide. Here we can see that it is iso to little bit hyperintense round oval well-defined lesion present at the roof of the fourth ventricle. Here we give the contrast to this patient. Here it shows the patches area of the enhancement with the round or well-defined nodular structure. Also, because it's spread through the CSF, so we have to scan all the neural axis. So here we can see that lumpy bumpy appearance on post contrast on lumbar dorsolumbar MRI scan. So, what is the CTMR medulloblastoma? Recently, we have talked that on CT scan, it will show the hyperdense lesion with the focus of the hemorrhage and the calcification with the areas of the cystic intratumoral hypodensity. The CT demonstrates a hyperdense lesion with eccentric calcification encompassing the fourth ventricle. This is our MRI. Here we can see that there is a hypointense lesion present in the floor of the or the roof of the fourth ventricle. This is a DWI image. Here we can see that it shows the beautiful restrictions and post contrast study it shows the enhancement. So here we have the medulloblastoma. So what are the differentials of the medulloblastoma? We can see that medulloblastoma has the differentials with its own medulloblastoma variant or atypical teratoid or rhabdoid tumor, choroid plexus papilloma, and Ranvier-Duclos disease. So differential diagnosis of the medulloblastoma, other two are very interesting. So first one is our pilocytic astrocytoma. Pilocytic astrocytoma is mostly present within the parenchyma of the cerebellum, while our medulloblastoma is present on the roof of the fourth ventricle. So we can differentiate in both like this. But interesting thing that differentiation between the medulloblastoma and ependymoma is very interesting. So here are some features. Here is our medulloblastoma and here is our ependymoma. So on medulloblastoma it present below the age of 6 to 11 years while ependymoma is present in 1 to 5 year of age. Origin is from the roof while origin of our ependymoma is from the floor of the fourth ventricle. On NCCT scan, here we can see that its hyperdense calcified 20% hemorrhages is rare, while ependymoma is isodense, hemorrhage and calcification are common. On CCT, or medulloblastoma will show the beautiful homogeneous enhancement, while the ependymoma will show the heterogeneous enhancement. On MRI, it's interesting that T1 MRI will show hypo on T2 iso2 hypo in medulloblastoma condition, while in ependymoma, T1 will show the hypo to iso, while T2 will show the hyper intense imaging. So here we have our beautiful medulloblastoma. In quick revision, we can see that the medulloblastoma is the most common malignant tumor of the pediatric age group, with very interesting most common second most common pediatric tumor with homer bright rosette appearance. Here is the beautiful small round to oval blue cells present with the homer bright appearance. In the histological, we have the classical medulloblastoma, nodular, extensive nodular, and anaplastic medulloblastoma. These three are our variant, while the classical one is the most common. Genetic, we have the WNT activated medulloblastoma, SHH activated medulloblastoma, non-WNT, non-SHH medulloblastoma. Classical medulloblastoma, as we just said, that we all have the four type or molecule subtype. Almost all the WNT type activated medulloblastoma. The classical one in present in the dorsal midline fourth ventricle, roof of the fourth ventricle. Pathology per se, we just discussed the round oval blue cell will be there and Homer with rosette appearance will be there. WHO grade 1. It could 85% chances there it will be in the midline. Rest of it could be laterally or in the one lobe of the cerebellum or infiltrative, but most common it will present in the roof of the fourth ventricle. Just we have discussed it. So vomiting, headache, psychomotor, ataxia, strabism, and spasticity will be the oval clinical feature in our child. So relatively well-defined round oval mass will be there. So here will be cystic hypodense area with the calcification, with a hemorrhage, with large hyperdense mass on CT scan. So CT scan, we can see that hyperdense mass with a hypodense cystic region with hemorrhage, hyperdense calcification. On post contrast study, it shows the homogeneous enhancement, then will lead to hydrocephalus. On MRI, it will hypointense on T1, hyperintense on T2. It will show the beautiful distinctions on DWR. On FLAIR, it will show the peritumoral edema. On contrast, it will show the either minimal or the patchy or the marked enhancement. So here is T2 and T1 metal image ISO to hypointense. Here on T2 ISO to hyperintense. Contrast, it is a patchy enhancement while lumpy bumpy appearance on the dorsal spinal tumor. So differentiation is medulloblastoma, ATAR, choroid plexus, thermoid ductal syndrome. So here is medulloblastoma and ependymoma. Ependymoma less than 5 year, medulloblastoma 6 to 11 year. Roof is the medulloblastoma, floor is the ependymoma. So thank you so much. I am Dr. Rohit. Thank you for watching this video.